There's one where, yeah, that's it.
Aw, you're my friend too, baby. You're my friend too. Yeah, I'm trying to join this stuff. And then I'm keep seeing somebody that's going to me naked. Where are you going? You have a date with Linda? Are you watching the one I watched? Oh. Oh, baby. He's trying to get on the screen. Hi, hi.
There we go. So is this picking up now? Great. Perfect. Well, thank you so much, Bob, for that very, very kind introduction, and Teo for the invitation to come up here and share a little bit of our research, our team's research with you. So I wanted to talk about the impact of depression on HIV outcomes as it relates to 90-90-90. And disclosures about grant funding. I don't have any conflicts of interest related to this talk. So I wanted to set the stage first. I think many of those engaged in HIV research will recognize the term 90-90-90, but just to make sure we're starting on the same page, if you've been doing anything with HIV in the last 7 years, you've probably seen this figure or its derivatives, the HIV treatment cascade that has really, I think, transformed the agenda of the HIV treatment research field, and has led to the articulation of these 90-90-90 goals. And 90-90-90 means the goal that 90% of all individuals living with HIV should know their diagnosis, that 90% of those diagnosed should be on antiretroviral therapy, and 90% of those on antiretroviral therapy should be virally suppressed. And these goals have been articulated because of pretty compelling scientific evidence that those on ART and virally suppressed are not infectious, in addition, of course, to preserving their own health, and that these goals, if achieved, would really lead to ending the AIDS epidemic. So it's led to all this language around we can end the AIDS epidemic if we achieve 90-90-90. A lot of funding is now focused on expanding ART, tracking systems to make sure that individuals are achieving viral suppression, that clinical care systems are held accountable for achieving those goals. So why am I starting a talk about depression by talking about 90-90-90? So the key message of this talk, which I'll spend the rest of the talk talking about, is that I would argue, and I think there's compelling evidence to support this statement, that achieving this goal of 90-90-90 and ending the AIDS epidemic will be difficult, if not impossible, if we don't also address the psychosocial needs of those living with HIV. So that's the central message of the talk and of most of the research that I've focused on. So to back up a little bit and kind of talk about what do we know about depression and HIV, it's kind of striking from the very earliest days of the epidemic, psychosocial needs of people living with HIV and AIDS were identified. Here are two papers from 1984, two of the first to really raise this issue, and one quote, I'm sorry, part of it's kind of cut off here by our menu, but how should mental health issues related to HIV/AIDS be addressed? How can mental health services be integrated into comprehensive care for people with AIDS? What is the appropriate role for community mental health agencies and alternative self-help approaches? I think it's kind of striking that nearly 25 years later, I think we're still wrestling with these same questions, essentially. So the overall burden of mental health disorders and adverse life events is much greater among people living with HIV than in the general population. Here's just one study documenting this. This was a systematic review and meta-analysis of prevalence of childhood sexual and physical abuse, intimate partner violence, and recent post-traumatic stress disorder diagnosis among HIV-infected women, done by Eddie Mochtinger, or led by Eddie Mochtinger from UCSF. It's been a real leader in thinking about trauma-informed care within the HIV care context. So we see that there is a very high prevalence of adverse childhood experiences, traumatic life events, post-traumatic stress disorder in this population. There are a number of other studies that have shown elevated prevalence of depression, other disorders among people living with HIV. And we know that there's a lot of overlap between mental health concerns and challenges in this population. So this is just one figure showing the overlap between mental health concerns, childhood sexual or physical abuse, substance abuse. There are a lot of co-occurring conditions that complicate treatment, response to treatment, and kind of escalate the needs of the population. And beyond mental health diagnoses, we know this is a population that often simply suffers from a lot of life adversity that adds up to big challenges to remaining engaged in medical care, good adherence, and really maximizing their own health. So this was just a cohort study led by Catherine Wetton from Duke University following over 600 HIV-infected individuals from the U.S. South. And over the period of a year, I mean, there are a lot of striking numbers here, but just to pick one, over half of these individuals lost a close family member. Family member died. A lot of financial stresses, a lot of illnesses or injuries to the individual or to their relatives, employment, and so on. But this adds up to a lot of challenges. So from the same study, we observed this dose-response relationship. This is work led by Michael Mugavero, now at Birmingham. Dose-response relationship between the lifetime exposure to traumatic life events and reduced antiretroviral medication adherence. So the more traumas the individual had experienced, the more likely they were not to have been adherent recently. We see a similar dose response between number of incident stressful events in the recent past several months and incomplete adherence. And focusing specifically on depression, where most of my talk is going to center, again, backing up to 1996, right after the launch of highly active antiretroviral therapy. So this is the transformative medical moment, right, in HIV care. All of a sudden we have these triple regimens that are extraordinarily effective in reversing AIDS, reversing HIV progression, and restoring health. And doctors were observing that many patients just weren't taking these life-saving pills, and why not? And so here's one of the first investigations of what was associated with poor compliance with ART, and from the abstract, compliant patients, among other things, had significantly less depression. Our data suggests that symptoms of depression and psychological stress be sought in patients with non-adherence. So here we are about 20 years later, a systematic review of over 111 studies of antiretroviral adherence, and depression being one of the strongest and most consistent factors that emerges as a marker of people with consistent barriers to adherence. So adherence, the likelihood of good adherence was approximately half in individuals with depression compared to those without in the systematic review. So all of this evidence adds up. This is just sort of a light sampling, but adds up to very strong evidence about links between depression and all these steps along what's now become known as the HIV care continuum, related to the cascade I put up earlier between diagnosis to linkage to care, receiving ART and adherence to ART, continuous re-engagement, retention and re-engagement in care, all being related to HIV outcomes. And depression, there's good evidence, is linked to worse outcomes along each step of that cascade, all the way out to predicting higher mortality rates. So just to focus on mortality for a minute, this is one of the earliest studies to look at the question of the relationship between depression and mortality among people living with HIV. This was from the HERS longitudinal cohort of HIV-infected women in the late 90s. And so this graph shows the risk of mortality among this cohort. And it's stratified by CD4 count here. So we see, as we might expect, that those individuals who entered the cohort with lower CD4 counts were much more likely to die than those with moderate or normal range CD4 counts. But we also see that within each CD4 count range, comparing those with limited or no depressive severity over the course of follow-up to those with intermittent depressive severity to those with chronic depressive severity. And this was based on essentially numbers of contacts where depressive symptoms were elevated. We see this dose-response relationship between depression and elevated mortality, regardless of CD4 count. And more recently, Jonathan Todd at UNC led a paper based on the WISE cohort, another cohort of HIV-infected women. 848 women here in this analysis followed for an average of almost 10 years apiece. And so what's striking about these two graphs, so this paper focused on the joint effects of ART and depression or depressive symptoms on mortality. So one of these two graphs shows the relationship between ART and survival. And the other graph shows the relationship between depression and survival. And what was so striking to me when I saw these results was the fact that you can hardly tell the difference between the two, right? So it's well established that ART cuts mortality risk in half. And depression is exactly as strong a risk factor as ART is a protective factor for this population. So here we have the reduction in mortality associated with ART. Here we have the elevation in mortality associated with being always depressed versus never depressed. And this relationship actually was the same both for the women on ART and the women off ART. So it doesn't only operate through antiretroviral adherence. And this paper used all these fancy methods to try to get closer to a causal inference claim. So we have a strong body of literature to date that links depression to adverse outcomes all the way along the HIV care cascade. So I'm about to present more results focusing on the same question. So why re-examine this question? Why do more analyses, more observational analyses, identifying associations? Why not move forward into action intervention? Well, we also are doing that. But there were reasons why our group thought it would be worthwhile to re-examine this question in a slightly different perspective for a couple of reasons. The first being that depression in pretty much all of these papers is framed as a binary condition, usually based on a screening tool or a severity, some sort of severity scale, like the CESD is one of the most common, the Centers for Epidemiologic Studies scale for depression. You get a score between 0 and I think 65 or so, and there are validation studies saying, well, the cut point of some use 16, some use 23, is the best cut point to discriminate likely depression from likely non-depression, but it's not a diagnosis of depression, right? It is a probable, it's not even really a probable depression diagnosis. These are elevated depressive symptoms. PHQ-9, the Hopkins symptom checklist, all of these are scales, right? And that's what we use in large epidemiological studies because we're not going to do a psychiatric diagnosis, full diagnostic interview on all these individuals. But that means that we are making an assumption. We're putting a label of depression on something that isn't actually necessarily depression. So is there really that much of a difference between someone who scored 22 versus 23 on the CESD where we drew that cut point and we're coding one is not depressed and the other is depressed? Is there really no difference between someone who is a 22 and a 0 on the CESD, both of whom we're coding as non-depressed in these binary approaches to depression? So there's that limitation of approaching depression as a binary condition. There's the second limitation of really approaching depression as a fixed trait. So a lot of these studies are cross-sectional or they're point in time. Here's depression at a point in time, and then let's look at outcomes over some period of time. And we know depression is not a fixed trait. It comes, it resolves, it's treated more or less effectively. It may go into remission, it may recur. There's a longitudinal time-varying aspect to depression which must be important for how it relates to HIV outcomes. And then the third reason is to think about what is the intervention question that these studies imply. So our traditional regression models with our 0-1 exposure they are implicitly asking the question, what improvement in outcomes would we expect to see if the exposure were entirely gone? And how realistic of an intervention goal is that? So no one with HIV will ever have depression again. It's not really very, very realistic. Or is our intervention goal to try to identify individuals with depression earlier in their course of illness, their depressive course of illness, intervene with more evidence-based treatments and better integrated treatment than we have currently, resolve their depressive illness earlier, reduce their symptomatology earlier, and thereby try to improve both their mental health and other outcomes. So if we frame the analysis differently, can we ask a question that has more intervention relevance? So with those as goals, we set ourselves the objective of developing a continuous measure of chronicity of depression based on repeated depressive severity assessments over time, and to examine the relationship of this time-varying continuous chronicity measure to HIV outcomes, really trying to look across the entire spectrum of the HIV care continuum, not just at one point, but trying to look all the way across the continuum. So just to kind of frame a little bit of how we thought about this, we can, kind of as I alluded to a slide or two ago, we might think about this continuous spectrum of depressive severity over time that might come and go, right? So we might have someone who is in the midst of a major depressive episode. With treatment, they gradually improve until maybe they reach full remission. Over time, their treatment may work less well for them. Maybe they suffer new setbacks, new personal setbacks. Maybe the medication stops working as well. Maybe their depressive severity increases. They start to struggle more, although not to rise above that threshold, which on our screening or measurement scale would classify them again as depressed. So the point is that person different from someone like this who starts in the same point, is well treated, and maintains that treatment remission status? Or how would their experience relate to someone who has long-term chronic mild depressive severity that never exceeds a diagnostic threshold, but is nevertheless not the same as having no depressive symptoms, compared to someone who really, in fact, does not have depressive symptoms over time? So these are the sorts of comparisons we're interested in trying to be able to make. So there's actually so we borrowed and adapted an approach that has been used pretty widely in depression treatment trials to try to quantify the benefit of depression treatment, the relative benefit of depression treatment interventions, specifically comparing medications, which is to develop a measure of days spent with depression, the converse of depression-free days. So, and here's how it works. So you start with some quantitative measure. So the PHQ-9 is one that's used in a lot of studies, and 10 is the established threshold for the PHQ-9. That's where that red line is drawn in most studies that would approach this from a binary perspective. But the PHQ-9 itself can range from 0 to 27. And if you go back to the original validation study on the PHQ-9, that 10 is the best single threshold if you had to pick one. It has the fewest depressed down here and the fewest non-depressed up there. But that original validation study provides better evidence for a different way of thinking about the PHQ-9, which is that there's this range under 5, which really corresponds to no depression. And there's this range above 15, where pretty much everyone in that range met criteria for a major depressive episode. And then there's this range between 5 and 15, which is just a little bit more mixed. And so the approach of trying to turn that into something quantifiable over time is to think about this range as a range where we're saying we're capturing a period of time in which this individual is not depressed. This is a period of time, we're capturing a period of time when this individual was most likely fully depressed or in the midst of a depressive episode. And this as a range in which we're capturing a period of time in which this individual may or may not have been depressed, had some elevated depressive symptoms. We'd like to maybe prorate this range between 0% and 100%. So if we, in a longitudinal follow-up study, have a depressive severity measure at multiple points in time, we could assign each of these points a value. And we could then dig back into our fond memories of high school calculus and the trapezoidal rule, taking the area under the curve. We could define this as a period of time in which the individual, we would say, was 100% depressed, because it's just the average of the 2 points, each of which are at 100. This is a period of time in which we would say the individual was spent 55% of their days depressed. Here we have 5%, 15, 35, just by taking the average of those points. And then we could actually turn this into a running average. So we're at 100% here, but over the first 2 periods, we have an average of 78. Over the first 3 periods, an average of 53. This individual's percent of time cumulatively spent with depression is going down because they have improved, but not as fast as it would be for the other person, the second graph we showed, which really stayed in this green zone throughout. And so this metric, so we're using days spent with depression, but the converse, days spent, or depression-free days, has been shown to correlate very well in depression treatment trials with other measures of response to treatment, diagnostic measures of response to treatment, to hold up very well as a valid measure of how much depressive burden the individual is suffering under. So we get this cumulative burden of depression, and we then use that as our exposure variable. So the data source that we leveraged in order to conduct this particular research was the CNICS, or the CFAR Network of Integrated Clinical Systems, which is a partnership of 8 centers for AIDS research across the country, each of which have established longitudinal cohorts of their, observational cohorts of their patients receiving care in their ID clinics. So it's kind of a data grab of all of the stuff in the medical record. But what these sites have done, which is a little bit unique, is because there are a lot of cohorts like that out there. You know, grab data from medical records. What these sites have done, which is a little bit unique, is they've layered on to this clinical data routine self-reported measures of behavioral health. So integrated into routine care at 7 of these 8 sites. There are, so every 4 to 6 months when patients come back for routine appointments, if they haven't completed one in the last 4 to 6 months, they get a tablet, they get a bunch of questions. So they complete the PHQ-9, they complete a few other things. So it's kind of unique. CNICS is unique in this aspect of having really rich clinical data with this really good validated set of behavioral measures layered on top of it. So among other things, CNICS collects demographics, appointment data, labs, medications, and diagnoses from the medical record, as well as these patient-reported outcomes every 6 months or so. And they capture mortality, both by site reports and by querying the National Death Index. So we took all CNICS participants from 2005 to 2013, 2005 being when these patient-reported outcomes were first rolled out at the first site, 2013 being our data cut at the time of starting these analyses, who were HIV positive and had at least 2 PHQ-9s separated by less than a year. So we followed people as long as they kept having PHQ-9s separated by less than a year. If they hit a gap that was more than a year, we censor them. If they leave care for more than a year, we censor them. Otherwise, we follow until death or until the end of the data cut. And the median gap between these serial PHQ-9s was 100, so about 6 months, 182 days, which is about the metric that has been used in many of these depression treatment trials that I described. So we wanted to consider 3 different outcomes. Again, we wanted to really kind of span the HIV treatment continuum. So we first looked at the relationship of this accumulating burden of depression to the risk of not showing for the next appointment. So here you are today, you've come to care, and at this point your cumulative burden of depression is X. What's the likelihood you're going to come to your next scheduled appointment? Will you show or will you no show? Second, we wanted to look at viral suppression, so detectable viral load. So again, here's your burden of depression through today. What's the likelihood that your next viral load will be above or below 75 copies per mil? These are both repeated measures, GEE. And then we wanted to look at mortality. So the cumulative burden of depression through today, predicting your risk of mortality in the next time period. So this is implemented with a Cox proportional hazards regression. And we used weights for a couple of different reasons. So we addressed confounding control using inverse probability of exposure weights. So this is a push in the class of models called marginal structural models. So rather than multivariable adjustment, we're dealing with confounding control using weighting. We similarly used weights to address selection. So is there informative loss to follow-up? Do we selectively lose, for example, the most depressed patients? So we address that concern also through weights. And then we also have a kind of this artifact of using routine medical data, which is that people come in more or less frequently. Someone might come in once a year for their medical appointments. Some other people might have multiple appointments in a year. Similarly with viral loads. So we want to account for that varying frequency. So we also addressed that problem through weights. So we have kind of a large system of weights that are addressing these three different potential sources of bias in the analysis. So we ended up with nearly 6,000 adults in the sample, contributing nearly 11,000 person-years of follow-up. There were over 55,000 scheduled HIV appointments for our first outcome, whether or not they no-showed. 19% were no-shows. 28,000 viral loads. 22% of those were detectable. And we had 158 deaths during follow-up. And the median percent of days spent depressed was 14. So a few descriptions of the sample. This is as the HIV epidemic is today, largely individuals in their 30s, 40s, into the early 50s. This cohort, because of where the sites are, is a little bit more weighted towards males than the national epidemic. These are individuals who, by and large, are in reasonably successful care. Most are on antiretroviral therapy. About 2/3 were virally suppressed at the time of, I think this is actually over follow-up time. And then these are some of the outcome data. So this all comes down to essentially three graphs. And this is a bivariable description of the relationship, but then I'll show you the weighted regression results that show the same relationship. So over here we see on the x-axis, all three of these graphs on the x-axis will have the cumulative burden of depression, the percent of days spent depressed since the first PHQ-9 measure. So we have those who have spent no days depressed, those who spent their entire follow-up time depressed, and then the people in the middle. And then on this scale, for this graph, we have the risk of missing your next appointment. And so you can see a little bit of a kink, but mostly a pretty clear dose-response relationship between those with the lowest no follow-up time spent depressed, a predicted risk of missing their next appointment of 15%, going up to over 20% for those with most of their or all of their time spent depressed. So if we put that in a regression model, we get an 8% increase in risk for this 25% increment. So again, this is comparing someone who spent none of their follow-up time depressed to someone who, there are a couple ways you can get here, either by you could have 25 of your assessments being in that 15 and above range and 75% being in the 0 to 4 range. Or you could have all of your follow-up time spent in sort of that middle range. That's another way that you can be here. And if we compare those always depressed to those never depressed, we see a 37% increase in the risk of missing the next HIV appointment. So similarly with viral loads, we see, again, just drawing a low S curve through the data, we see a pretty consistent dose-response relationship between the percent of time spent depressed and the risk of having a detectable viral load. So it's a 5% increase in that risk, with a 25% change in percent of days spent depressed, and overall a 23% increase in the risk of a unsuppressed or detectable viral load, comparing those always depressed to those never depressed. And then mortality, similarly, here the picture is a little bit different in the sense that you kind of get a sense from the picture that there's sort of an elevated, consistent, twofold elevated hazard of mortality, pretty much regardless of the level of elevated depressive symptoms. So it's not strong evidence against linearity, so we still fit it as a linear term in the regression model. But there's some visual suggestion that really the difference is between no time spent depressed and any time spent depressed. But overall, there's an estimate that we approximately double the mortality rate comparing those who spend their full follow-up time depressed to those who spend none of their follow-up time depressed. So putting all of these pieces together, the kind of the high-level summary is that this increased chronicity of depression, days spent with depression, is associated with higher risk of appointment no-shows, higher risk of detectable viral loads, and higher mortality rates, and that even modest increases in the time spent depressed led to these clinically meaningful increases in risk. So kind of a take-home message we can take from that is that even though eliminating all depression is not practical, this would make the argument that routine depression screening and high-quality treatment, which could shorten depression duration and reduce depressive severity and prevent recurrence, could be expected to have meaningful impact on these HIV clinical outcomes. Which brings us back to our starting message, which is that can we achieve those 90-90-90 goals of the ending the HIV epidemic mission without addressing these mental health and psychosocial needs? So just to kind of circle back to that message a little bit, again, we're back in this cascade. This is from 2011. I think the cascade has improved some since then. But we know there's still large gaps in who has actually achieved an undetectable viral load compared to everyone living with HIV, especially in resource-poor settings in the world. And then we can put this HIV treatment cascade, where we see these really large gaps that we know we have to address, next to our best estimates of what the depression treatment cascade looks like. So we know that in HIV clinical care, as in primary care, as in most non-psychiatric specialty care, that about half of cases of depression go unrecognized clinically. We know that of those recognized clinically, about half go without receiving any treatment whatsoever. And we know that even of those who receive some treatment, especially in non-specialty settings, the vast majority do not receive what we might call adequate treatment. So we know that depression treatment really, or the response to depression treatment really depends on what type of not what type of treatment is provided, but essentially the quality of the care that's provided. So antidepressants are not one size fits all. You typically start low and you have to dose to response. And in primary care and in HIV care, and it's not surprising, these are not psychiatrists. They weren't trained in psychiatry. It's not their primary mission. Most typically, what we see is a low-dose antidepressant that's started and may be checked again in a year. So a lot of the work, which I haven't talked about today, but the intervention side of the work that our group at UNC has collaborated with others on, has been trying to say, well, how can we improve that adequacy of care in non-specialty settings? How can we provide decision support to HIV providers to allow them to understand follow algorithms around rapidly reassessing patients, rapidly increasing doses until we actually get response to treatment, or integrating evidence-based psychotherapies that can achieve remission. We do know that if adequate treatment is provided, remission is highly likely. So we have really good interventions for depression if we can get them out. So kind of the thought question, the challenge question is, what would it take to achieve 90-90-90 in depression care? What would it take to get 90% of those accessing the care system who have a need for depression treatment to be identified? What would it take to get 90% of those identified as having a need for depression treatment to actually be receiving treatment? What would it take for 90% of those receiving treatment to have achieved remission of their depression? So we have good evidence for how we could achieve this. We could achieve this through routine screening in our medical settings. We could achieve this through decision support models for starting treatment and dosing to response, which would be highly likely to achieve remission. So my argument, my position is that this is also what it will take to reach 90-90-90 in HIV care. We have to address, resolve these psychosocial needs. Again, I focused on depression. The umbrella is much wider than that. But we have to address these psychosocial and mental health needs to resolve the barriers to consistent care engagement, medication adherence in the long term that are going to be required to make people successful in treatment for decades for their own health and to really make possible the public health vision of ending the AIDS epidemic. So I'd like to close with some acknowledgments. Again, thank you to Teo and to Bob for inviting me here. Milton, a special call out. We're collaborators on U19s funded by NIMH that focus on scaling up evidence-based mental health interventions in low-income settings. A bunch of great collaborators at UNC and my recent postdoc, now out of the fold, tenure-track position at Brown, and other collaborators, UAB and the CNIX Network, and funding from NIMH and USAID. So thanks for listening. And happy to take questions or have any discussion.
That's
more than
what
happy.
We're here for. I'm glad we had a good time for discussion. It's so thoughtful and creative, I think, and just really important. Fran.
First of all, let me start by saying I love your work and thank you for this presentation. I've obsessed about this. I don't do research on HIV and depression, but I obsess about the topic because I train people about it. And I just want to make a couple of comments that you might want to bear in mind in your future research.
Mm-hmm.
One is that we don't have great treatment for depression. So you can't assume that. If you look at the STAR study, and I don't know if you're familiar with that study, but if you look at the STAR study, where I think they pretty much tried to make sure people were adherent.
Yep.
The first step was only 50% remission.
Right.
No, 50% response and one-third remission.
One-third, yep.
And then the second step the same. So
right.
really, you can't roll it out and expect good response, at least not with medication, without a very sophisticated set of algorithms. So it's not like we have great treatment and we're not using it. I mean, maybe the therapies would look a little better, but they're not so great with people who are so depressed they can't even participate.
Mm-hmm.
That's one thing. The other thing is that I've gotten really sick of looking at the HIV care continuum. Primarily, I mean, in the beginning it seemed like a miracle, but now I think we're completely overlooking mortality because once you're dead, you're not on the continuum.
Yeah.
And I really think, and you're probably in a great position to do it, we need something besides the HIV care continuum. That's nice, 1990, but it doesn't tell you all the people who die young from depression, who die of opioid overdose, who die of all the complications of mental health disorders,
right.
alcoholism, hepatitis C.
Right.
So I think we need to reframe it, and you seem like just the right person. That's just a suggestion. I really think we need to move to a different level of conversation.
Yeah. Thank you for those two comments. So I agree that our treatments for depression are not at the same place that our treatments for HIV are. So treating depression is complicated, especially in people with co-occurring anxiety, PTSD, trauma history, substance abuse. These are all complicating factors. However, we could do a lot better than we're doing, right? So what STAR-D did demonstrate, so STAR-D was the largest trial of antidepressant treatments in the world, I believe. It was over 4,000 people in the early 2000s. And they really developed this model of non-specialist provision of algorithm-driven antidepressant management, which is what we used in our trial of depression management in HIV patients. And the whole concept is, yes, you can train primary care providers to prescribe antidepressants better than they're doing it currently. And yes, if you do that, you only get a 33% remission in the first stage with citalopram. And then if you go to second-line treatment, you get another third who respond. And then then it gets harder. The third step was not, there were very few who additionally responded. But 2/3 is not bad. 2/3 is a lot better than we're getting currently, right? So the point is that if you could improve care so that, for example, what we did in our trial was we had depression care managers in the clinic. And so their job was to interact with the patient and then go to the HIV provider and say, so, this person is back after a month and they're still very depressed and you still have them on citalopram 10 milligrams. The algorithm would suggest this would be a good time to go to 20. It's still the provider's decision, but that decision support makes it possible for them to move forward. And so we found that providers, their initial prescription and their dosing improved dramatically with that decision support. And patients did achieve good outcomes. And no, we didn't get 90% remission, right? But they did a lot better than they were doing before. So,
and let me just finish.
Yeah, please.
But you know what? No, I agree with all of that. But when you give talks, because I run a training grant, when you show them the results of the STAR-D study, they're very disappointed.